We are very pleased to have with us today Dr. Michael Sullivan-Tibbs. Dr. Tibbs, Sullivan-Tibbs is the Quality Assurance Program Manager and Specialty Clinic Supervisor for the Tennessee Valley Healthcare System of Nashville and Murfreesboro, Tennessee. Dr. Sullivan-Tibbs has worked in the behavior and psychiatric fields for more than 25 years. He worked at a Midwestern psychiatric hospital in the early 1990s while in undergraduate school. He worked for the state court system in the early 2000s after earning his doctorate degree from the University of Tennessee, Knoxville. Dr. Sullivan-Tibbs has been with the Department of Veterans Affairs since 2010, working in Louisiana, Georgia, and Tennessee. He is also an adjunct professor of the Department of Social Work at a local HBCU in Nashville, Tennessee. Outside of the VA, much of Dr. Sullivan-Tibbs' work is surrounding mental health in the Black community, lecturing on the multi-generational trauma that has often been unaddressed within the Black community. He also has been educating or sustaining an anti-racist society and building social equity among marginalized communities. Would you please join me in welcoming Dr. Sullivan-Tibbs today?
Thank you, Dr. Kathy. I was listening to that saying, I wonder who that person is. He sounds really interesting. Well, I appreciate the invite. I've had the been fortunate to be invited several times to speak on lots of stuff dealing with social inequity and things like that. And this is a privilege to come to MTSU as well. I see former colleagues here as well, which gives me pride because I'm not alone in the audience. So that's really cool. And don't worry, I took my mask off, but we're social distanced and I'm fully vaccinated, triple. So we should be okay. The theme of this month, which is Black History Month in the United States, is really American history. But the theme is Black health and wellness. But we're gonna focus on those in-between lines of Black health and wellness, which are the disparities that still remain today. And I think it's quite apropos for fledgling social workers who will be out in the field doing the good work that social workers do, which is a lot. So when someone asks you, what does a social work do? Say, do you have a week for me to explain all that we do so that you can completely understand it? It's not just picking up the phone and calling to tell a parent that you're gonna take their child, or that you have a food meal ticket for them so that they can get lunch or breakfast. We do a lot more. We are clinical across the board, and I say that very ubiquitously. We're clinical at the macro level. We're clinical at the meso level. We're clinical at the micro level, because it takes a clinical mindset to look at all those different concentric circles of living to really do the work. So with that being said, we're gonna jump on. And as you see, I tried to be creative with the PowerPoint. I know there's a new system out there. Well, it's really not new. It's called Prezi. I tried, and it was not my forte, so I went back to the old standard PowerPoint. So as I stated, the theme is Black and health wellness. But there has been historic disparities, unfortunately, in the United States with Black healthcare from the first time a person of color from the African continent stepped foot on this continent. And that was before the transatlantic slave trade. And then during the transatlantic slave trade, millions more stepped foot on these lands. but their healthcare was not the prime objective. Now, I won't go too far into it because the presentation can go lots of ways and we only have an hour, but I'll just throw a little tidbit out there to you. But during the times of slavery, the antebellum time and other times, Black healthcare was a focus, but it was a paradox. It was only a focus to continue to do the enslaved work. So it wasn't for their own betterment per se. But there's a saying that's out there. I don't know if you've heard it. It says, when Black folks catch a cold, or when white folks catch a cold, Black folks get pneumonia. Do you guys understand that kind of concept? Cool. All right. Yeah. So before we jump into all that, we're gonna go back to what I'll call the impetus, which is our biases, the biases of those who are in power. There's a conscious bias and there's an unconscious bias. So for a conscious bias, for example, let's say you're watching, and this is not a plug for Good Morning America or CBS or the Today Show, but let's just say you watched one of those three that come on at the same time. And you hear an anchor say, wow, that person, referring to an African-American person, is very nice looking. And she's reporting quite well. She's very articulate. But did you notice her dreads? It would have been more professional if she had straightened her hair and be a reporter. That is a conscious bias because it's looking at something that does not seem to fit in with mainstream and attributing a trait to it that's negative. If you look at our local station, I believe it's Channel 2, there's a young African-American lady on who's a new street reporter. I forgot her name, but she wears her hair completely natural. And I thought that was a very powerful statement. And it's unfortunate that it has to be a powerful statement, but it is in today's day. It is professional for women of color, Black women specifically, to wear their hair in their natural, coiled, curly, kinky, dreaded, or plaited, or anything. And there's history around that as well. If you want to take a little sidebar, the history of plaiting or cornrow or braiding your hair was historic in the times of slavery, where those women would impart messages in the braid and how it's formulated to actually describe roads or to describe rivers of escape. So there was a meaning behind that if you want to look into that a little bit more. But that's an unconscious bias. And why did I put that out there? Because in every field, from media to medical to academia to research to all of these fields, there's an unconscious bias. We all have it. I have unconscious biases. I have conscious biases. The caveat is when you can recognize your conscious bias is directly impacting your decision, and that decision directly disenfranchises the person that that decision affects. So let me give you an example of an unconscious bias. We're looking at the same TV show, and it's showing some Black dancers, young adolescent dancers, or playing basketball. And you see the commentary back and forth between the reporters, and they say, wow, you know what? They really have rhythm. I wish I had rhythm. But they're typically good at dancing and basketball. Now on the surface, if you're in a collegial relationship and you're reporting and things like that, and you have those on-air commentary, on the surface, it may seem benign. You may have no ill will internally, but the message and the impact of it can still be devastating to an individual, because that is a very unconscious bias. It's almost like the horn halo effect. Oh, because they're Black, they're naturally enabled to dance. That's not all true. Or if you're Black, you can play basketball. I can't play basketball, and I'm 6'1". Never could play basketball. I ran track and I played tennis. That was what I was good at. But jumping and trying to shoot something, I couldn't do it because I couldn't see because I wear glasses. So I'm not innate for basketball. But those are those tropes that can be damaging. And many people utilize those tropes and those unconscious biases I would say more often than not on a non-racist mentality, it's just unaware. And because they're unaware, because in their social circles, there aren't many or if any other groups of people that look like them or look like the other person that they're talking about, I should say. And so we have to educate them. We have to help them see that the world is big and vast and that there's different people around. So these are all important because it goes back to providers providing care. And I want to give you that little history. And these concepts are quite important to the catchphrases nowadays that social workers knew about for many years, close to 100 years or so in our profession. But now we've coined them, diversity, equity, inclusion, and access. So DEIA, access. You have to have access. So it just lets us know, oh, did I click this or did you click it?
I did because we were having problems with
Oh,
Zoom.
okay.
So we're good to go now.
I said, oh, okay. I was like, when did I do that? I'm really good. No. So it goes to those things. And on here, I got equity, but I don't have access on here because I wanted to update that to access. Access is the newer term that people started to recognize. Yes, you can have diversity. Yes, you can have inclusion. Yes, you can have equity. But if the systems still don't have historic barriers broken down, then there's no access. And if there's no access, the whole motion is a moot point. So we have to have access and they have to be together, working in tandem, working in concert. And basically, you just have to recognize that all people have an inalienable right to exist free of oppression in any social domain. I'm using those catchphrases that you guys should know about: social domains, your living, your social, your church, your spiritual, your work, your community, different things like that. And then providers have to recognize this. That provider-patient relationship is pivotal. I have many providers in my healthcare to keep me moving on this planet. And I had to come to be very courageous myself to speak with my providers about how they approach me. It is not arrogance. It is not being the angry Black man, the trope. It is not being threatening or intimidating. It's stating, this is the way I need you to treat me and talk to me because I'm going to afford you the same respect. And if I misspeak, I'm going to apologize very quickly and ask for education. So for example, I have a physician who is an Asian doctor. He's Indian, and India is part of Asia. And he lives here, and he's the same age as me. And he would come to me and he would say, Mike, your vitamin D level is very low. I'm very concerned. Now, mind you, complexion-wise, they would say I'm lighter skinned, Black, fair skin, and I'm lighter than the doctor that I'm talking about. And I say that because when he was mentioning that my vitamin D was so low, he made it seem like it was an intrinsic, flawed characteristic in my being of my affiliation to the African American or the African diaspora, which is flawed in scientific research. Anyone with a lot of melanin in their skin, no matter their ethnicity, is going to have low vitamin D because our skin is blocking the absorption of certain things in sunlight. If you have less melanin in your skin, you're going to absorb it more, i.e., if you are of European descent, or if you consider yourself white American, you're going to have more vitamin D in your system, right? Science is going to prove that. That doesn't mean innately that you, because of your historic diaspora, is better than another. It just means that genetically speaking and evolutionary, your adaptation made you more amenable to absorbing vitamin D. But if you have more melanin in your skin, you're typically in tropical and arid and desert climates where you don't want a lot of absorption because it will do more damage to your skin. So you have that protection. So I had to explain that to this provider, and he looked at me and said, I bet you he was thinking, who is this? Such and such, such and such. But I wanted him to understand when you talk to me about my healthcare, please don't come with a pejorative frame of reference, or don't come from a reference of inadequacy or less than, but come with an awareness that because of my genetic makeup, my historical diaspora, that there are some things that are going to be different, but it doesn't mean that it's worse or that it's intrinsic. Do you guys follow that? Okay. I just wanted to say that. We don't have to. Do you have questions? And I don't mind questions in between. It helps me. I leave this up here for you. One thing that I do, and I also teach, I never read from the PowerPoint. I put the PowerPoint up for you guys because I know this stuff, or I should know it. And I just kind of go off script, but I bring it all together for you guys. But I just want you guys to see that as a frame of reference. So we're going to jump back to, so we talked about history and we talked about different things. Now, how do you get to addressing healthcare disparities? Well, you got to have providers that look like the patients. Well, how do you do that? You got to set forth a frame of reference or mechanisms to hire people that look like the people that you're serving. That means that institutions from governmental, educational, private, individual have to make concerted efforts to ensure that they are addressing any systemic barriers of ism that blocks out others from being able to have access to interviews. So access is still an important part, not just for the patient, but for potential providers. So you want to make sure that you have a diverse panel. If you have a panel of all men and you're interviewing individuals, but there's no woman on the team, there could be potential barriers preventing a woman from being hired. I'm not going to go into the mindset of those on the panel. It could be some personal biases, or it could just be unaware. Like I said before, you're just unaware. So we have to educate you to say, we need to be aware. We need to put forth the effort to be aware. A lot of folks, if you look at the news, oh, I don't want to learn that stuff. I don't want to do it. It causes me stress. It causes me to be uncomfortable. Well, reality that I live in, according to me, Mike, and you can join me in this world if you want, is that the state of being uncomfortable is the state where growth occurs. The state of being uncomfortable is the state where growth occurs. When you are a toddler and you're trying to walk, you're uncomfortable and you're unsteady and you fall, you hurt your knee, you bump your head, but you keep doing it. But you have to be uncomfortable to push yourself forward to grow. And then you learn to walk. And then you're driving. And then all parents are like, ah! But anyhow, that's a whole nother story. But you have to be uncomfortable in order to grow. And we have to not look at that uncomfortable sense as a negative. That uncomfortable sense is growth. It's challenging us. So I put in here some different articles with references that you guys could look at on your free time about certain things that help us to create an environment that will promote DEIA, diversity, inclusion, equity, and accessibility. And that is critical race theory. We've heard about that. And everyone's saying, I don't want my children to learn critical race theory. Well, facts are your children aren't learning critical race theory. Critical race theory was created by attorneys, many scholars, and it's taught in law school or higher academia in college. To try to teach critical race theory to a 6 or 7-year-old is like trying to teach that 6 or 7-year-old calculus. You teach age-appropriate knowledge at the time. Well, you can say, well, Josie is Native American. Josie doesn't like to be called Indian. She likes to be called Native American. that is teaching critical race theory in essence, but you're not saying, oh, because I'm white, I feel bad because she used to be called Indian. When you know better, you do better. So we learned that language and words mean something. So when someone tells you their preferred preference of how to address them, just go with it. It doesn't hurt you. If I said, please address me as Dr. Sullivan-Tibbs, address me as that. Or if I say, please address me as we, us, and they, please address me as we, us, or they. I say he, him, and I, or me, or whatever, or you just say Mike. It's easier for me. But you go with the flow with what someone's preference is, because it doesn't hurt you. It's their preference, and it shows respect for them, even if you don't understand. And on a sidebar, that'll give you a little bit of chance to say, hey, after we address your medical concerns, I have a question if it's okay with you. You put the power back in their hands. Can I ask you, can you help me understand why you choose this way of acknowledgement as opposed to this? I really want to understand because I have other clients. That's a teachable moment. That is healthy in healthcare. So just wanted to talk about that. But here's a paradox, and specifically among Black Americans, is that because of the history of Black Americans in the United States, where they have been treated less than and sent to the side, there's a paradox where you would think that if they have a Black provider, they would be more receptive. But research shows that sometimes that's not the case. Because of those narratives that have been ingrained generationally, that Black is less than, we're not as intelligent, we're not apt to follow through, then even us Black folks start to believe that. So when we go to a provider and they're Black, oh, I don't believe what she's saying, I'm gonna have to go over here to this white person. Even though you have that history of some white folks not treating you with respect. And that's that real paradoxical thing. And that really is the underlying meaning, the underlying answer I can give to that is trauma, generational, longitudinal trauma. And we too have to address how we view things. Go ahead.
Wanted to comment on that, Dr. Mike, and say what you stated is very true. However, there are studies that show that African-American people live longer when they have physicians who look like them.
Absolutely, absolutely. And I'm glad you pointed that out, because I like to show all the different sides as much as possible, and that's great. They do live longer, and some of the anecdotal is that anecdotal information is that they are seen, quote unquote, by that provider because that provider has a shared lived experience. And they don't just knock it off and say, oh, don't worry about that. It's not, it's okay. So they are seen. That's anecdotal. But there's also quantitative research that says the same thing. So that is so true. Oops. Go here. So clinical steps of engagement: ask questions. Ask them if they understand what you're talking about, discussing. That's just normal. It could be for any person, Kermit the Frog, Miss Piggy, or another human being. Ask them, do you understand what we just talked about? Because a lot of providers talk in a provider-ease language, where the lay person is like, and then they leave. What did your doctor talk about? I have no idea. They said something about this was broken and this was going on. And they leave out not knowing. And that I consider malpractice, in my personal opinion. Because if your patient doesn't know what's going on, how are they to make changes to improve their existence? So we have to take the time to ask them if they understand and have them repeat back what you said. That's what you're going to do when you do, oh, I'm telling my age. Those who remember, we used to do called process recordings. Y'all don't do that anymore, where we actually would record our sessions and then we had to type out word for word what was going on, and then we had to analyze what we said and how that intervention may or may not have worked and different things like that. But that's another story. But that is an important component of of ensuring that your client knows what's going on. Go back to being open-minded. If someone tells you their lived experience, believe them with regard to their healthcare. I can give you another example. One of my great aunts, she passed a few years ago, but she was 96 years old. And at the age of 88, she went to her provider, who was a younger provider, and she said, you know, I think I have lumps in my breast. And he looked at her and basically she told us, he was like, well, you're older. I wouldn't suspect that you have breast cancer. Well, she kept having some pains and she went to another provider who happened to be of color, a Black female doctor. And the female doctor decided to run tests, and lo and behold, she had stage 3 breast cancer. So she went to the doctor and the doctor talked to her, and this is how my great aunt was. She said, well, we recommend a double mastectomy and reconstruction. How do you feel about that? At 88 years old. Because otherwise she was pretty much healthy within reason. She had medications, she had different things like that, but within reason of her age and cohort, she was pretty healthy. And she looked at the provider, because I think I was there, my mother was there, and her husband was there, and her son was there. And she looked at her husband, my uncle, who recently passed at 97, I believe. She was older than him, 10 years older, so that's why. She was proud of that. She said, well, I already got my husband, so we could do whatever you need. And I thought that was pretty prophetic and profound of her, but she felt comfortable to be free to say a very bold statement, I would say, like that to a provider, because she was heard, she was seen by a female doctor of color for her. Now, mind you, she's 88 years old. A lot of people say, oh, you're over here, you're done. But no, when you get 88, you don't want to be done. Right? So we shouldn't assume that of someone else. And so she had that and she lived to be 96. So it's important to build that trust. So why is understanding the history of BIPOC, and that's the other term, Black, comma, Indigenous, comma, other people of color. Now you're probably wondering, why don't you just say Black or individuals or people of color? Because we are one group of people of color. And sometimes when you look at systems that can change in legislation, if you don't specify a particular underrepresented and marginalized group, they're gonna get swept into the collective and their specific unique issues may not be addressed. Did you? So that's why I do separate, and many scholars separate Black, comma, Indigenous, comma, and other people of color. It's not to say that we want to be separate, but we have uniquely specified needs that need to be addressed uniquely. But why is this important? Anybody want to wager to say, why is this important? Why are we talking about this? Anyone? She seems like she wants to say something. Go ahead, take the mic. Be bold, be brave. Yes, for the Zoom. Yes.
I guess for me, it's not about healthcare. Kind of when I think about what you just mentioned about Black, Indigenous, people of color, it reminds me a little bit of the case that happened not too long ago with Gabby Petito, and how everybody and their mother was willing to help find this girl. Everybody had the FBI, a lot of folks, even John Washington, Dog the Bounty Hunter, everybody was finding this girl, social media, and everybody. But then there were several social media accounts who were African Americans, including myself, who was like, okay, that's all fine and dandy. Y'all use every resource in America, even the whole world, to find this girl. But can y'all do the same thing for African Americans? Can y'all do the same thing for Indigenous people? And it pretty much shows how double standard everyone can be, because there's still Indigenous people who are still missing, and nobody is doing the same thing, even African Americans.
Yes, and you brought up a great point. And one day, maybe I'll be invited back and I can talk about that as well. But the salient theme and all that is historic systemic racism and isms that block individuals from access to the provision of care in any life domain that everyone should get equally.
I would
Yes.
also like to add, which some people see as very threatening, when you talk about people of color in a collective manner that way, they are no longer the minority, as some people like
Correct.
to imply. You're the minority. Actually, people of color make up the majority
Of the world.
of the world. When you look at us as a collective, and not just, oh, you're African American, you're Indigenous, or you're this, we're people of color, and
Correct.
collectively we make up the majority in terms of population. But when we talk about power structures, we're talking about something very different.
Absolutely.
So the term minority is fading out.
Mhm.
And, that's not the way we see that now as offensive to apply, to characterize people as a minority group.
Correct.
We may be an underrepresented group or a marginalized or an oppressed group, but let's call it what it is. We're not the minority. We are actually the majority.
And I'm glad you mentioned that too, Dr. Kathy. Words are power. Let's break that down. If I digress just 1 second, you keep me on track with time too. You just say, hey, move it, and I'll jump. When you say minority, the underlying meaning of that is that we're inferior. When you say underrepresented or marginalized, that denotes someone else who's in power put those restrictions on you. So it's not innate in you. Do you follow the difference? Yes, I hope. Okay. So I put up this one book. I read lots of different books, and this one book I thought was pretty simple with understanding disparities across the board. There's so much literature out there that you can read, but this one was really a nice little snapshot of disparities and historic trauma among the African diaspora in the Americas by Dr. Joy DeGruy, called Post-Traumatic Slave Syndrome. But she talks about so many things, and I think it's a great conversation. If any of you want to read that, I think it can help influence a lot of your thought in many different areas, to include healthcare, because she talked about that. So that's part of some history she talked about. When you look at these images, you see folks in chains, tattered, arriving. They weren't on vacation. They didn't enjoy the trip. They didn't enjoy where they landed. They weren't happy, contrary to Gone with the Wind, the movie, and contrary to other movies that depict the experience of enslaved individuals. And I always say enslaved individuals, not slave. Slave is a pronoun, like he, she, and things like that. Enslaved is different. It goes back to the power of the words. And so those folks weren't happy. They weren't given nutrition, proper nutrition at the time. Now, mind you, no one was really that nutritious back in the day, but within reason, they had less than the collective with regard to their standard of nutrition, which affected them physiologically, generationally. Racism is the root cause of a lot of health inequities. You see the things, they would divide the body up in different parts, and they would analyze those. Some things they would evaluate the skull, and if there were certain nodules on the skull, they'd say, oh, this meant that this person was developmentally delayed and they will never amount to something or this or that. And it was no science behind it. It was just pseudoscience. But people ran with that, and by running with that, it affected those communities very negatively and harshly, and many died. Trauma. If you're being beaten, you're not really being taken care of. If you're being raped, you're not being taken care of. If you're giving birth and within 30 minutes of giving birth, you're forced back into the sugarcane fields or the cotton plantation or anything like that, your health care is not a prime objective. And then there's myths about the Black folks, that they don't feel pain, or that they have tails. You know, little tails. That was another myth too. So they weren't completely human. So we can do more things to them because they're really not human. They don't feel pain. They have tails. They could be beasts of burden. We don't have to afford them things that we would do for us, our civilized individuals. And that's how they justify it. In order to do harm to someone else, you don't see them as an equal, because that would be a cognitive dissonance that would prevent you from doing harm. But you have to see them as something less than, and that makes it a lot easier to swallow and to do things to them. So this different relationships that Black people have, fear with going to mental health, going to physical health, because of this history. Why am I going to go to someone who doesn't see me as a human, one, who beats me, who afflicts me, who practices things on me without scientific research? And we're going to talk about those things. And some people say, why do you always talk about the tuskegee syphilis thing? Why do we always talk about the Gila trait from Henrietta Lacks? Why are we talking about that? That happened years ago. We don't need to worry about that. We're not doing that now. Well, truth is, we're still doing things to people that have no power. And why are those things important? Because basically, people were lied to, and they were allowed to perish due to illnesses that could have been treated very easily, or your genetic substance was used without your permission to do other things, and your family nor you were ever compensated. So we'll talk about that too. And who has always been disproportionately at the lower prong of all of this abuse? Black women. And the sexualization of Black women, and just the abuse of the Black woman's body. So you probably heard of the father of gynecology, and Dr. James Marion Sims. He practiced a lot of barbaric things on a particular enslaved Black woman in the presence of many people in Central Park, New York. Had her up on a pedestal, did things to her without anesthesia, without anything to prevent her from feeling pain. He would also inject her with things that would do harm to the normal individual. But he could justify it because she wasn't human, she was enslaved, and Black folks don't feel pain. This was barbaric. And her name was Anarcha. So if you ever want to look those things up, go ahead.
Yes, and Dr. Mike, she was not the only one.
She was not the only one,
He
yes.
performed multiple surgeries on her without the benefit of anesthesia, and actually developed the speculum
Yes.
from the work that he did on this enslaved woman who had no authority to give consent for the things that were done to her body.
Correct.
And only recently, I think they took the statue down in New York of Dr. Marion Sims.
I believe they did.
And much of this early work was done, his science was done in the antebellum South.
Absolutely, absolutely. So some people will say, well, did the ends justify the means? I have to say no, because there was no respect of person, benevolence, trust, informed consent, or any of those things. notwithstanding, yes, you learned things, but how you learned it. There's possibilities that you could have learned the same information from an ethical practice. Go ahead.
There's still a lot of debate about just what you said.
Absolutely.
Does the ends justify the means? There's a premier debate between Dorinda Ojenuga
Yes.
in the literature and other scholars who basically felt that because of the time that Sims practiced in, that his work was actually justified. So, and we're not talking about this in, 1930 or 1920. I think those articles were written like in the 90s.
Correct.
And so there is still this prevailing belief that this work,
Gave us the knowledge that we could do today.
right, even though Black women were disproportionately affected by the lack of knowledge
Correct.
that physicians had at the time, and even when treatments were available, such as anesthesia, white women would get anesthesia and the Black women did not. So it's imperative that we understand history, where we came from, so that we don't repeat some of the same behaviors, and to understand where some of the arguments that we still are fighting with today come from. What is the root?
What is the root?
Our prior speaker talked about or showed us the video of the physician in Indiana who
And I
died.
have that in here as well.
Oh, okay.
Yes.
And one of the things that stood out in that video was the fact that the physician who was treating her did not take her pain seriously.
Correct.
And so there's a historical root that you touched on that prevails today in medical practice. Black people don't experience pain the same way that white people do. Therefore, Dr. Sims can, perform these very rustic surgeries on African-American women that he would not perform
On white women.
on a white woman.
Correct. And why is this important? Like I said, I bring it back to you. Thank you for mentioning that. And the physician in Indiana, and I'm from Indiana, it broke my heart. And I know the hospital. I worked there before. The trope was she intimidated the nurses so they couldn't provide their care. I have to challenge that and say she advocated for herself as a Black woman. To boot, she was a physician who knew the medical protocol, and she forcefully advocated for herself because she was dying from COVID. No one is going to be very calm when it's a fight or flight situation. Do you think you would be? Oh, I know I can't breathe very well. I have a child I need to take care of. I'll just wait on the doctors to come in, even though I know that they're not doing what they need to do. I'm just going to remain calm because that's going to be the care that I receive. No, no human is going to respond in that way if they don't have a deficit going on already. You're going to be very animated. You're going to speak on that. And you need to take everything in its complexity and in its situation. So she ended up dying, and that's unfortunate. And I do have that video that, we'll let you see. And I'm gonna speed up a little bit. How much time do I got?
You have 10 minutes if you're gonna allow for questions.
Yes, I'm gonna speed through. So the Tuskegee syphilis study lasted for 40 years. Dr. Marion Sims was in the antebellum South. So you got some years in between that, and then you got into the recent years of 40 years. And then you also had Henrietta Lacks issues with Johns Hopkins Hospital. And they have a history of used to stealing Black folks historically and using them, unbeknownst to the public per se, But the Black community knew about this. They would steal away folks and perform barbaric and experiments on them, and many of them died in the pursuit of knowledge, but no reverence for that Black life. So I just wanted to talk about that. And I put some other things in there as well for you guys to review. And it's not just Black folks, because here's the deal. In the United States, they see it very binary, white and Black. So anybody else who's of color is going to be swept up under the Black pedestal, so to speak. So that's why, as a Black person, we have to speak out, because those others will ride our coattails to get the benefits as well. And I put those things in there for other marginalized groups, just for you guys to look at and see the similarities. So be that as all that to say is, you guys are going to know about this if you haven't already known about this. All these unethical practices culminated with the Belmont Report that had to be created. And it was created to govern practice of research with human subjects. So the three main foci are benevolence, justice, and respecting a person. So anytime you engage in human studies, you have to have those three things. And that is one way to try to protect it. I say diversifying the workforce. These are the key takeaways. Learn from different cultures, evaluate common practices that may be hindering progress towards a diverse workforce or healthcare provision, different things like that. And I circle back to, why is this important? And this goes back to Dr. Susan Moore, who during the apex of the COVID virus pandemic, she was in, I won't say the hospital, just because we're on Zoom, but it was in Carmel, Indiana. And Carmel, Indiana is likened unto Brentwood to Nashville. So when you say you live in Nashville to family members or friends, but you actually live in Brentwood, you just kind of use the same term. I live in Nashville, because people are like, well, what is Brentwood? Well, the same thing for Carmel. You say Indianapolis, but Carmel is a subset, and it's a highly affluent area, historically affluent, white privilege. And she was a physician, and she cried foul play with her treatment. It reached headlines. So her son is now left without a mother, because they did not do the protocol that she said, please try. They thought she was drug seeking. There was no reason for her to be drug seeking. They had her medical profile. And she died, and I left the YouTube video. How much time do I have for questions?
About 8 minutes.
Yay. Please ask questions, because we're on Zoom. And was my mic working? Okay, good. I'll be kind of late now to ask. Please speak, please speak. Don't be afraid.
I have a question.
Oh, he has a question. Here you go.
My question is one that I'm not sure how to word it with it. I don't know how to word it, so I'm just going to say it. How's that? I can really appreciate what you're saying about how when somebody who has a doctor who looks like you, I have a doctor that looks like me, I'm going to live longer, right?
Right.
Okay. Not necessarily.
Not necessarily.
Right. Okay. So a doctor, a Black person who has a Black doctor is going to live longer, correct?
In some cases.
On a research level. They're seen because they have a lived experience. Those were the words being used, correct? Here's my question. I hear those words. They are seen and have a shared lived experience. And with that context, is this becoming where it is? Is it going to be equal but separate again? Like, that concerns me.
I get what you're saying.
But I also understand it. And I can say that
right.
coming from a perspective of, I know what it means to have somebody who has had my lived experience. And I'm not talking from a racial context.
Right.
I'm talking about from other experiences in my life where somebody who gets what I've gone through, somebody who understands that, and that means something to me, who understands what I've gone through. So therefore, that therapy works, okay? So from another context, but that concerns me is that, what are your concerns with that context?
I would say that two things can be true simultaneously, if you follow. So yes, there may be some separate but equal, but only on small micro levels. And if everyone learns a little bit of each other, then it will start to coalesce. Does that help a little bit? Because we have to learn, because the truth is, male healthcare and female healthcare is different. So that is a separate, but it's equal that we get healthcare, correct? But we have to learn about both in order to provide the best emerging healthcare possible. So it's two things are true at the same time, and they need to coalesce.
So I guess what my question is, what would be the end game? Like, what do we want to see? How would we want to see society and healthcare develop so that the best outcome would be?
So one side would be not to put all the responsibility on the providers. They have to learn their collective group of patients. At the same time, two things true at the same time, the patient has to overcome whatever historic trauma or cope with the best way they can to advocate for themselves as well to their provider. Go ahead. Oh, is it on? Okay, you have to turn it on. Sorry.
I think it's also important that we understand the importance of eliminating racism, dismantling racism.
Yes.
We all have a responsibility in that. Whether you're Caucasian and never witnessed racism, or whether you're African American and you experience microaggressions on a daily basis, we have a responsibility to dismantle racism. We don't have to go from one extreme to the other.
Correct.
I think there is this fear in this country that if I'm not the majority, or if I become more inclusive of others, what does that mean to me and my group? And it really means that it's better for everyone because we dismantle racism. And I believe that we can dismantle racism because racism was created. It is a construct. So therefore we can deconstruct it and we can live, and this may sound Pollyanna, whatever it is, but we can all live harmoniously when we begin to see that there are enough resources for all of us. The pie is not something that has to be divided where you get more and I get less. Including more people of color in the medical field does not mean, oh, white people get less medical providers. It just means that you're becoming more reflective of the country and the world. And so a win or an up for one group does not mean a loss for another. We can all see this as a win when we understand what the real culprit is. And the culprit is institutionalized racism. It's not what people do on a one-on-one, it's what happens in this country systematically, and how we vote and put people in office who continue white supremacy. And it is up to us to decide that is no longer tolerable, whether it's in healthcare, education, the criminal justice system, or wherever. And I think, just because you are not a victim does not mean you don't have a responsibility.
Absolutely, absolutely. Oh, she had a question?
Is cultural intentionality or diversity, is that something that would be taught at like an academic level for medical people going into medical field, or is it currently? Just curious.
I'm not sure of their curriculum, but I would wager that teaching cultural humility, which is the newest term, and cultural fluidity should be taught in any aspect of dealing with any human being. And cultural humility means I may understand my lived experience. I may not necessarily understand your lived experience. Both are true. I have to respect them both, mine and yours. But then you have the dialogue with that individual, and that's the humility part. The fluidity is understanding, just like language is not dead, it is live, it's constantly changing and acting. We could see that in the New Webster Dictionary. Before, the word ain't was not a word. Now, ain't is a word in the dictionary because language is fluid. So we have to look at dealing with different ethnicities in a culturally fluid mechanism. The other thing that I personally don't like is when I see the media and even individuals that are indoctrinated in relations of different ethnicities or race keep saying it's helpful for all races. Well, science tells us and has told us for many years, there's one race. It is the human race. We're Homo sapiens sapien, which is very wise man. There were a time when there were multiple different hominids on this planet, Neanderthal and different things like that. They interbred, they fed, they breeded out. They were different races. But this group of individuals that are walking this planet now is one. Yes, we look different. We have different eye structures, different hair textures, different skin, different things like that is only skin deep because of our historical environmental habitat. But we're one race. And if we can get that down everyone's throat, then maybe we can move the pendulum till we can eradicate racism, to see that we are the same. Just like in families, you may not look just like your brother or your sister or your mom or your dad, but you're the same family if you haven't been adopted per se, genetically. Go ahead. Are we over on time?
Well, no,
Okay,
we're over. That's
okay. Oh, I'm good. Yeah. Yeah, go ahead.
I want to make a statement. When you made a point about how Dr. Sims, who was a gynecologist, and how he used to perform heinous acts on African American women to perform these procedures,
Mhm.
it it reminds me a lot of I don't know which course I was taking. It was either with Professor Prather or Coxwingo. It was one or two, but they mentioned how back during the time when African Americans were leaving slavery, they experienced heinous acts where they were pretty much treated like as lab rats when it came to using new, when it came to testing vaccinations or cosmetics or what have you.
Mhm.
So that also came to mind when you mentioned about all the other inhumane stuff we had to endure back then.
Absolutely. And groups are still enduring these things. That's why human rights is human rights. And we have to practice that in every level that we see it, especially for social workers. Because I'm a social worker, I'm gonna really put the mantle on your backs as the next generation to really be true change agents, to be vocal, to not stand down, to not believe the trope, oh, if you go into social work, you're not gonna make a lot of money. No. If you don't make a lot of money, that's your decision to not make a lot of money. There's ways to get money legally, ethically, and professionally because of the knowledge and the expertise that you bring to the table, either in a healthcare setting or a private setting. We need to also change our narrative to be the discipline that other people respect equally as well. And once they do that, then they respect the work that we do with those clients that are underrepresented, that are marginalized as well. So we have a lot to do to change and evolve ourselves as well as social workers. Others? Did you enjoy the presentation? Was it meaningful, or are you just saying that just because you had to come to class?
Everyone on Zoom hated
Everybody on Zoom hated it. There's people on Zoom?
Yes, very informative and provided an excellent historical perspective. Thank you.
Oh, wow, thanks. Are they still on it or are they off?
They all said, we got to get out of here.
Okay.
No, they have, thank you.
Okay, well, thank you, guys.
Thank you,
Thank you.
Dr. Mike, for
Yeah.
joining us today. You are
Yeah.
always a pleasure to hear from,
Thank
and
you.
I hope you will join us again.
Yes, invite me again. Thank you. Thank you. I'm curious to know what the Zoom people were saying. How many people were on Zoom?
There were a total of 16 throughout the entire presentation.
Wow.
Yes, Dr. McElder. So, yeah, so probably between here and there was a total of about 35.
Wow.
Yeah. So
And what did y'all say?
throughout